So good evening, everyone. I'm Talah Nammor, and today we're gonna go over questions that are like heavily tested in pathology, clinical, like depending on your lectures in pathology and clinical. So let's start. I'll do just like yesterday in the pharma. We're gonna see a question. We're gonna underline together the important things, and then we'll answer it. All right. So let's start. Yeah. So I'll read. Okay. So a 61-year-old woman is brought to the emergency department because of crushing substernal chest pain at rest for the past 2 hours. She's diaphoretic. Her temperature is 37.5, pulse is 110, respiration is 21 per minute, and blood pressure is 115. We saw that we have ST elevation in 1, AVL, V2, and V4. The angiography shows that we have 80% stenosis in the left anterior descending artery. طيب guys, what do you guys think are the important things that we need to underline that will help us know the answer? Do you guys have any like idea?
The substernal chest pain, crushing.
Okay. So okay, the substernal chest pain is important صح لأنه it will direct us إنه نحن عنا like let's say myocardial infarction, all right? But هون specifically we have an 80% stenosis in the left ascending artery, so we can know that basically what is causing this like this myocardial infarction برأيكم? Atherosclerosis. Okay, so basically we have coronary angiography and stenosis. This stenosis caused the myocardial infarction. So this stenosis, okay, is caused due to what?
Atherosclerosis.
Exactly. So the question is asking, what's the initial step in the pathogenesis of atherosclerosis? So what do you guys think the answer is? So atherosclerosis is caused by what? Okay. We have a D. What do you guys think? D. Okay, let's see. Actually, guys, the answer is E, because before the low density lipoprotein oxidation, we need to have an endothelial cell dysfunction. صح? We have to have dysfunction in the endothelium of the coronary arteries for all of the cascade to happen. صح ولا لا? Yeah. So basically, the first thing that has the initial step for everything to happen is the endothelial cell dysfunction, and then we're going to have the other steps where basically we're going to have basically oxidation of cholesterol and so on. تمام? So be careful and know what is the initial step is important. تمام? Okay, let's move on. تمام. So in this question, we have a 53-year-old man. He came to the emergency department because he has headache, blurry vision, and confusion. They did everything and he still died. And then we can see this autopsy. So what do you think is important? The headache, the blurry vision, and confusion. Why? Because these are symptoms of what, guys? When you have headache, blurry vision, and confusion. B. Onion skin, hypertension. Yes, exactly. So the headache, blurry vision, and confusion, and the oliguria, and all of these things, they show us that basically we have hypertension. And when we look at the autopsy that they did, we have the onion skin appearance. So what makes the most sense is B, severe hypertension. So you guys are right. We have severe hypertension because of hyperplastic arteriosclerosis or the onion skin looking vessel, all right? And the things that we underlined right here, this show you that it's a hypertensive emergency, or like there's a very extremely high blood pressure, because at high blood pressures your like the vessels in the eye are going to get affected, and that's why we're going to have blurry vision and headache and confusion, all right? But basically the biggest giveaway is the way the artery look, the hyaline arteriosclerosis, all right? Okay. In here, a 41-year-old woman man with a history of hypertension and hyperlipidemia as brought to the emergency department by his wife. He has difficulty breathing after choking on food at dinner. He's unconscious and pulseless. Despite appropriate life-saving measures, he dies. When you examine the heart, there was a necrotic pale yellow plaque in the left circumflex artery. So where do you guys think the original plaque came from? So he has hyperlipidemia. This shows that he has atherosclerosis. And the necrotic pale yellow plaque in the circumflex artery shows that, come on, this is due to atherosclerosis. So what is the most common place of atherosclerosis in the whole body? D. Okay. Do you guys think it's D? Does everyone agree? Okay, I'll take the silence as yes. Yeah, it is actually D. It's the abdominal aorta because the abdominal aorta is the most common site of atherosclerotic plaque. So in this case, because he has hyperlipidemia and because of the way it looks, like the plaque looks, we know it's an atherosclerotic plaque that moved from as an initial place, and usually abdominal aorta is the most common site. All right. Yellow. A 62-year-old man comes to the physician because of fatigue and decreased urine output for 2 weeks. So we have fatigue and decreased urine output. He has not been to the physician for many years, and we see that his urea concentration is really high. So we have some kind of renal dysfunction, all right? And and then we have heavy proteinuria. Then they showed us this image. I know, guys, when you first hear, like, look at the question, you'll be like, okay, this is renal. Why are we looking at this? But look at I want you guys to look at the photo with me in here. What do you guys see? Like in here, what do you guys see? Hyaline. Exactly. So we have hyaline arteriosclerosis. طيب, hyaline arteriosclerosis. What do you think it's more common with? We said that A. صح. Basically, it's more common with diabetes. Okay. The hyperplastic, exactly. So guys, hyperplastic arteriosclerosis, the onion skin is usually more common with the hypertension. And in here, أصلاً in the choices ما في hypertension, so it would أو بلا في hypertension. So that's why we removed it, because hypertension is associated with the arteriosclerosis, the onion skin. But in here, the hyaline is more associated with diabetes. All right? Yeah, malignant hypertension. Oh, okay. So both of them are there, but the hyperplastic arteriosclerosis is more associated with malignant hypertension. But both of them can hyaline arteriosclerosis can be caused by hypertension and diabetes. All right, but in this case, it's more of a diabetes. Is this clear? Okay. Tamam. So we have a 42-year-old man. He has systolic heart failure, secondary to amyloidosis, okay? And the donor heart is obtained from a 17-year-old boy who died in a motor vehicle collision. When we examined the heart, we saw that there was a flat yellow-white discoloration with an irregular border in the luminal surface of the aorta. A biopsy of the lesion is most likely to show which of the following, guys. So it's giving atherosclerosis, right? Because it's yellow and it's dystrophic calcification or lipoprotein laden macrophages. Okay, whoever said EYE? And whoever said AYA? I don't know. Okay, valid. Type. Let's check together. It's basically lipoprotein laden macrophages, or the foam cells, because exactly the macrophages are going to eat the LDL, and we're going to have the foamy macrophages. And the yellow discoloration can show you that it's a fatty streak, or like it's related to fat So that's why lipoprotein-laden macrophages is going to make more sense than dystrophic calcification. أصلا حتى calcification usually is white, it's not yellow. تمام? Is this clear? Okay. Yeah. In a very young age, right? Yeah, like the age is not directly like it's not related with like the possibility of having the fatty streaks or not. No, it depends on your LDL and your vitals in general. You get me? So yeah, they can be seen in a young age. Tamam. Yalla, let's move on. So basically, a 62-year-old man, he has persistent cough for the past 2 weeks. Okay, he has discomfort in his chest. He has a sore throat, headache, and low-grade fever, which is treated with acetaminophen and rest. His father died of a myocardial infarction. He has hypertension and hyperlipidemia. He smoked 1 pack of cigarettes daily. He's taking enalapril and atorvastatin. His temperature is 37 degrees, pulse is 70, blood pressure is 145 over 90, so we have increased blood pressure. And this is the x-ray that we see. So let's look at the important things in here. We have a 62-year-old man, so he's old. He has hypertension, okay? And you can see that his blood pressure right now is really high. And if we look at the image together, what do you guys see? Don't you feel like the aortic arch is a bit too, yeah, so the aortic arch is larger than it usually is. So okay, wait, I gave you the answer. But okay, guys, out of these things, what do you guys think we should do? I know you saw the answer. I hope you guys did not like Rigzo, but like D, emergency surgery. Okay. Does everyone agree? Yes. طيب. The answer is going to shock you guys, and I'll tell you why. So basically, it's not emergency surgery. Why? Because, okay, this is giving basically thoracic aortic aneurysm, but if you guys look at his like vitals, they're stable. So we have to, first of all, kind of like confirm that he has TAA, and because he's stable we can confirm it. طبعا if he was not stable we would directly take him to surgery, but because he came into the like into the clinic or the emergency with stable vitals, we would do an angiography and then we would take him for surgery. Is this clear? Sorry. Okay. تمام. The most important thing is that you guys were able to see that it's it's an aortic aneurysm. I don't think you're going to get tested on like management, so don't worry. تمام. بس I wanted to like see if you guys knew that this is an aneurysm. Anyways, let's complete. So, okay. A 43-year-old man, he came from Chile, I think it was. I don't know how to spell this. Comes to the physician because of a one-day history of upper back pain and difficulty swallowing. So he has dysphagia. He has had pain in his shoulder and knee joints over the past 10 years. He's 190 centimeter long, okay? And he weighs 70. His blood pressure is 142 over 86 in the right arm and 130 on the left arm. So we have discrepancies between the blood pressure on both sides. Physical examination will show a depression in the sternum, and you guys can see it in here, and a grade 3 out of 6 diastolic murmur at the right upper sternal border. A CT scan of the chest with the contrast is shown. So before we go into the CT, what do you guys think is the most important like keywords in the question that can kind of guide us into whatever the diagnosis is? F, different pulses both sides. Okay. Marfan, exactly. So he's really, really tall, okay? And then there is discrepancies, different pulses on both sides, and depression in the sternum or the, you can see it in here. Wait, let's go to the image. And we have a murmur. So you can see in here, we have the pectus excavatum. So pectus excavatum is part of Marfan syndrome. And then if you look in here, this is the aortic like the aortic arch, and it's really dilated. So we have aortic root dilation. So this is Marfan syndrome. So in Marfan syndrome, what is the most important, like what is the thing that we expect in them? We expect that they would have cystic medial degeneration. So whoever said F, you're correct, because all of the signs are giving us Marfan syndrome, and we can know that Marfan syndrome, cystic medial degeneration, is very common. All right? تمام? Okay. تمام, let's go. Okay. Moving on. A 24-year-old woman comes to the physician because of a 3-month history of progressively worsening joint pain. All right. He has had diffuse aching pain in her knees, shoulder, and hand bilaterally for the past few months, but the pain has become much more severe in the past few weeks. She also reports night sweats, generalized malaise. On physical examination, the radial pulses are weak. There is erythematous nodules over the legs. And in here, the most important thing is we have like high ESR. So let's look at the things that can help us diagnose this patient. She's a young woman. All right. She has joint pain, so she has arthralgia, and we have radial pulses that are weak, and her ESR is high. So what do you guys think it is? Someone said E. Do you guys agree? Takayasu. صح, it is Takayasu arteritis because it's called the pulseless disease, and she has decreased pulses, radial pulses. So, and she's a young woman, so it would make sense in Takayasu as the answer. Amazing, guys. Okay, yellow. A 50-year-old, if you guys want to read the question and like be interactive with me, I don't mind. Relax, I would love it. Okay, I'll read it. Fine. So a 50-year-old man comes to the physician because of recurrent episodes of chest pain and rapid heart beating over the past 2 months. During this period, he has weight loss, malaise, pain in both knees, and diffuse muscle pain. 5 years ago, he was diagnosed with chronic hepatitis B infection. Okay, so he has chest pain and rapid heart beating, palpitations. He has chronic hepatitis B infection, and he was given tenofovir to basically manage his hepatitis. And if you guys, so his vitals are so, and there is no other abnormalities. And you can see severe ulcerations on the ankles and calves. If we look at the lab, we can see that the P ANCA was negative. So what do you guys think is the diagnosis? So something that a vasculitis that is very common with hepatitis B. And the P ANCA is negative, so it's not P ANCA positive. What do you guys think? D, pan, no, F. طب حددوا D ولا F. E. It's not E, like for sure. Yes, F. Okay, let's check it out. It's D. Whoever said D بالأول, you're correct. Because polyarteritis nodosa is greatly associated with hepatitis B, and the P ANCA is not positive. C is D ANCA, no. Wait. Okay, wait. So basically, I included. Okay, I included in here the explanation of why. So in C, okay, the P ANCA is usually positive. Okay, so in Schrag-Strauss syndrome, the P ANCA is usually positive. So that's why it's not C. We have here negative P ANCA. Okay, and a lot of you guys said F, granulomatosis with polyangiitis or Wegener's. Wegener's, we usually have upper respiratory tract like symptoms. We're going to have what is it called? Increased ESR. هلا هون نحن عنا increased ESR, so it doesn't help. But basically, we have upper respiratory tract like infections usually. Not infections, sorry, involvement. And in this question, there wasn't upper respiratory tract like involvement. It was just chest pain, rapid heart beating, and hepatitis B. Okay? And hepatitis B is extremely associated with polyarteritis nodosa. Is this clear? In small vessel vasculitis, we would see the positive C ANCA and P ANCA. In small cell vasculitis. Yeah. And then here it's negative fats. Do you get why it's not like... Yeah, I get it. Okay, perfect. Okay. So if you guys see negative P ANCA, hepatitis B, and that's the most important. طبعا ال ESR أكيد is high. you'd think of polyarteritis nodosa. تمام؟ Okay. تمام. Here. A 63-year-old man comes to the physician because of a 2-day history of fever and blood-tinged sputum. He also had a productive cough for a year and has 3 episodes of sinusitis during this time. So keep in mind, guys, عنا blood-tinged sputum and fever and sinusitis. So we have the nasopharynx involved, we have the lungs involved. The physical examination will show palpable erythematous skin lesions over the hands and feet that do not blanch on pressure. There is ulceration of the nasopharyngeal mucosa and perforation of the nasal septum. So again, the nasopharynx is involved. The serum, the serum creatinine is 2.6. So we have some kind of kidney dysfunction, all right? And we have proteinuria and RBC cast. So we have the triad, guys: nasopharynx, lungs, and what is it called? And renal. So what do you guys think? صح, it is granulomatous polyangiitis because we would see the C ANCA titers are elevated. Guys, did you watch the Dirty Medicine video for this? Because if you guys did not watch it, صراحة, I really recommend, because it really helps. Because for me, vasculitis was really bad. Like, I've always struggled with vasculitis, and it really, really helped. Because for this one, he has like this he makes it like there's like a nice mnemonic فشوفوها, guys. And you know, guys, like how Pathoma said, it's like a C that goes through, like it goes through the nose, the lungs, and then the kidneys. So that's why C ANCA would be elevated. Okay, slay. تمام. يلا, moving on. A 45-year-old man with asthma, okay, came to the physician because of a 1-month history of progressively worsening shortness of breath and cough. He has a history of chronic sinusitis and foot drop. Current medication is albuterol inhaler for his asthma, inhaled corticosteroids. He has diffuse wheezing above both lung fields and tender subcutaneous nodules on both elbows. His leukocytes are high, and mainly they're made up of eosinophils, and the serum creatinine is high. So what do you guys think it is? يعني we're saying eosinophils, asthma, so it would make sense for it to be B. Exactly. So, eosinophilic granulomatous with polyangiitis, we're going to have, it's important إنه يكون عنا يا أما they're going to show you إنه eosinophils are really high, or they're going to show you a history of basically مثلا atopic dermatitis or asthma. You get me? Yeah. Okay, perfect. تمام. Let's move on to this question. A 57-year-old man is brought to the emergency department for crushing substernal chest pain at rest for the past 2 hours. So we're thinking, طبعا worst case scenario, we're thinking MI. تمام? The pain began gradually while he was having an argument with his wife, and now is severe. He does not take any medications, but he has smoked cigarettes for the past 35 years. His temperature is 37, pulse is 90, respiration is 20, blood pressure is 115 at 65. There's an S4 gallop, and they showed us this ECG. What do you guys see on this ECG? يعني صراحة it's highlighted, يعني it's obvious. We have ST elevations, صح? So we have ST elevations from like leads V1 to V6. So we're thinking of, isn't it diffuse? It's not diffuse actually, because if you look at AVL, like, okay, maybe it's a bit elevated, but it's not as elevated. يعني هلا عليكم guys, when they show you an ECG, the ST elevation is going to be dramatic, all right? Like, okay, I understand why you might think this is an ST elevation, but no. it's the most dramatic. It's the most dramatic in here. فit's only ركزوا معي, it's only ST elevation in those V1 to V6. So it's not diffuse. تمام. هو يمكن هاي الصورة ما منيحة الصراحة, بس blame it on Am, but not me. But I'm telling you, in the exam, they're going to show you a photo that has severe, like the ST elevation is going to be really clear. You're not going to like mistake it. تمام. فنحن we know he's going through an MI because أصلا guys pericarditis, if you guys you're saying pericarditis, his temperature is low for pericarditis, okay? Do you get me? And it was sudden. But we think of an MI. So what do you guys think is the answer? Because we're saying LAD is occluded. Perfect. So C, occlusion of the left anterior descending artery. Is it clear why, guys, it's not pericarditis? Yeah, okay. Yalla, moving on. A 55-year-old man, he comes to the emergency department and a dry cough and severe chest pain beginning that morning. 2 months ago, he was diagnosed with inferior wall myocardial infarction and was treated with stent implantation of the right coronary artery. He has a history of hypertension, hypercholesteremia. He takes a bunch of medications. His temperature is a little bit elevated. Oh, his pulse is fine. Respiration is يعني a little bit elevated. Blood pressure is elevated. He has a high-pitched scratching sound best heard while sitting upright and during expiration. So عنا dry cough. And 2 months ago, he had an MI. تمام? We have the scratching sound best heard while sitting upright and during expiration. What do you guys think it is? And when we checked the ECG, now we saw diffuse ST elevation. So what do you guys think it is? It's 2 months after Dressler or constrictive pericarditis. Because it's 2 months after, I think we would think of Dressler, صح? Because constrictive pericarditis is kind of E or B. But it's not early, like it's literally 2 months ago, like it's 2 months after. Anything that's after a period of time, it's gonna be Dressler syndrome, okay? Because we know that Dressler syndrome, it usually happens 2 to 10 weeks after MI, and it's been 2 months, so it's within the 2 to 10 weeks period. صح ولا لا? And wait. Okay. Oh, never mind. Do you get why, guys, it's Dressler? Wait. Yeah, because you have to look at the period of time. يعني أكيد it's not going to be, let's go back. Cardiac tamponade, it's going to have a different scenario where you're not the triad, you know, the triad where there is muffled heart sounds. We're going to have GVD, like distended jugular veins. It's not cardiac tamponade. Constrictive pericarditis, usually it happens right after, like close to it, not 2 months after. Aortic dissection, no. Reinfarction, no. Pulmonary embolism, no. The most thing that makes sense is Dressler syndrome. Is this clear? Wait. So the rest. Okay. Tamam. If you guys have any questions, stop me at any time. Tamam. Okay. I'm not gonna read the scenario, guys, because it's long. But look at the photo. You can see that we have occlusion in the LAD. So what do we expect the ECG to show? So if we have an occlusion in the LAD, the ECG is going to show exactly ST elevation in V1 to V6. شاطرين. تمام. طيب إذا عنا نحن ST elevation in 2, 3 and AVF, which one is affected? RCA. صح. صحيح. طيب وإذا عنا ب AVL circumflex, exactly. أنا guys كنت حافظة إنه AVL, the L is for left circumflex. I know it's like LAD كمان إنه فيها L, but like I don't know why the L with LCX made more sense. You get me? Because 1 to 6 LAD is kind of very easy. You get me? Lateral leads. Anyways, is this clear? Yalla, next question. 2 days ago, a 61-year-old man, he was admitted because of acute myocardial infarction. Okay. He had sharp substernal chest pain that worsens with inspiration and improves when leaning forward. Okay, oh my gosh. I hope you guys did not see this. Cardiac examination shows a scratchy sound best heard over the left sternal border. So, histopathological examination of the affected tissue is most likely to show which of the following findings? Okay. Yeah, because it's only 2 days, so it's really like this MI has been really like soon. It's gonna show up with neutrophilic infiltration. Okay. طيب, if it was 10 days or like 2 weeks after, what do you guys expect to see on a microscopic level? Exactly. Granulation بيكون في عندنا macrophages. صح. طيب, after like let's say after 2 months, if we saw the heart grossly, what are you going to see? The scar. Exactly. It's gonna be like white. Okay. Slay, guys. تمام. هلا يلا, a 76-year-old man is admitted to the hospital for evaluation of sudden onset chest pain. Okay. 3 days after admission, he develops severe shortness of breath. Despite appropriate care, the patient dies. The left ventricle of the heart is autopsy. You can see it here. Which of the following most likely contributed to the patient's cause of death? So let's look at the image. So he has shortness of breath, he has sudden onset chest pain, and only 3 days after being admitted for an MI. Okay? And then you can see in here, I think I have the image right here. You can see in here, what is this, guys? Hello? Hi, guys. So this is inside the heart, and these are the chordae tendineae. Tamam, they're attached to what muscle is this? Are you guys saying anything? Okay, papillary muscle. Slay. So this is the papillary muscle, and we can see that we have a rupture. صح? Because you can see that this is one of the ends and this is the other end. So we're going to have rupture of the papillary muscle. So which of these do you think is the answer? C, pseudo aneurysmal dilation of the left ventricle. Do you guys agree? C. What causes, okay. What causes, okay, نحن عنا a ruptured papillary muscle and you can see hemorrhage. So basically, it's not, basically it was kind of, it's an ischemic damage. So the blood to the papillary muscle was cut off by whatever cause. And this is what led to this. So which artery supplies the papillary muscle? Is this question hard? Okay, I'll just show the answer because no one is saying anything. But the answer is A, occlusion of the posterior descending artery. So basically, this is the most posterior, this is the papillary muscle, the posterior medial papillary muscle, okay? Maybe it wasn't clear because like we don't know exactly where on the heart this is, but like it would make sense for the rupture of a papillary muscle to be caused by ischemia, صح? Yeah. So basically, usually the posterior descending artery, out of like all of these options, the only one that shows like there is ischemia that would lead to the papillary muscle rupture is A. Tamam? Is this clear, guys? Okay. Shall I move on? I'll just move on. Tamam. So, an 80-year-old man is admitted to the hospital after the sudden onset of substernal chest pain and shortness of breath while sitting in a chair. Tamam. So we have we have substernal chest pain and shortness of breath, and she was already admitted to the hospital. So we think of MI. Tamam. This man had hypertension and type 2 diabetes, and he has been smoking for the past 42 years. 4 days after admission, he became tachycardic and then loses consciousness. The cardiac monitor shows irregular electrical activity. Cardiac examination shows a new systolic murmur at the apex. So they did everything, but then he dies. So 4 days after an MI, what do you guys expect to see microscopically? A, macrophages. 4 days after admission? Let's see. So we're going to see macrophages. The neutrophilic infiltrate is usually there for the first 3 days, all right? But 3 to 10 days post an MI, we're going to have macrophages. So we're going to have hyperemic granulation tissue with a lot of macrophages. Is this clear? Okay. Tamam. This is really easy, guys. So basically, someone has HIV and he basically has like a bunch of like you see these lesions. He has these lesions on his leg, and let's see, HIV, and he has. And when we took like a biopsy, we saw multiple spindle-shaped cells and leukocyte infiltration. What do you guys think is this? First of all, what's your diagnosis? A. Okay. Wait. Basically, HIV, so he's immunocompromised, okay? And he is like this is kind of a vascular tumor. Do you guys remember Kaposi sarcoma? Yeah. So Kaposi sarcoma usually is at the extremities, and you can see in here the right heel. There are those lesions. So, and even the biopsy itself said spindle-shaped cells. Spindle-shaped cells is very, very high yield for Kaposi sarcoma. So what causes Kaposi sarcoma? Human herpes virus 8. And because, come on, the patient is immunosuppressed, but it would make sense and like, oh, basically he'd have a human herpes virus that can cause Kaposi, okay? Because HHV can cause multiple things, not like يعني specifically only Kaposi, okay? I'm saying HHV, not HHV8. Like لأنه في عنا a lot of herpes viruses. Is this clear? Okay. تمام. تمام. A 70-year-old man, he comes to the emergency department because he has brief losing of consciousness and he collapsed when rising from a chair. Okay? So عنا losing consciousness and he collapsed. He did not sustain any injuries. He's been having dizziness. Whenever he stands up, he has dizziness. He has smoked 1 pack of cigarettes. He drinks beer. He drinks whiskey. اللي بتكم. He takes medication, okay, dutasteride and tamsulosin for benign prostatic hyperplasia. His vitals are fine, but his blood pressure is normal. But when he stands, it goes really low. Okay. And then on physical examination, we heard an murmur, a low-pitched rumbling mid-diastolic murmur heard best at the apex. So what do you guys think this is? So I know consciousness, he loses consciousness, he feels dizzy, his blood pressure can decrease, and we have a mid-diastolic murmur that's rumbling, and it's best heard at the apex. C. Okay. Do you guys know specifically which cardiac tumor we're talking about? Myxoma. Exactly. طيب, one more question. What is the most common place where these myxomas are at? The same symptoms. Exactly. Usually, myxomas are most commonly at the left atrium, so they would cause symptoms that mimic mitral valve like pathologies. Great, guys. Oh, كان لازم أقول plopping sound. My bad, بس يعني you guys got it correctly. Okay, next. تمام. Blood cultures are sent to the laboratory and an IV is started. Okay? The echocardiography shows a large oscillating vegetation attached to the tricuspid valve and multiple small vegetations attached to the tips of the tricuspid valve leaflets. There is moderate tricuspid regurgitation and there's no abnormalities. Ejection fraction is normal. Everyone's saying D. And you guys are right, because a right-sided infective endocarditis is usually the most common in IV drug abusers, and it's usually due to Staphylococcus aureus. Slay, guys. Yalla. A 51-year-old man comes to the physician for 2 months of intermittent low-grade fever, malaise, and joint pain. He has a history of recurrent dental abscesses requiring drainage, but otherwise he's healthy. Tamam? So we have dental abscesses. His temperature is elevated, he has fever, and a physical examination shows a new holosystolic murmur in the left midclavicular line that radiates to the axilla. There are linear reddish-brown lesions under the nail beds and tender villous nodules on the bilateral thenar eminences. 2 sets of blood cultures shows Streptococcus mutans. Tamam? What do you guys think is the mechanism at which the pathogenesis of this disease happened? So, Streptococcus mutans is Streptococcus viridans, صح? So, what do they do? D. Leaflet calcification and fibrosis. Are you guys sure? It's for sure not myxomatous degeneration ولا antibody cross reaction, because it's not F. Yeah, the answer is actually F, because Streptococcus mutans, which is kind of like which is basically from it's a kind of Streptococcus viridans. What is their like virulence, or like the thing that starts all of this? It's the dextrins, right? So the dextrins are going to result in the formation of a fibrin clot, and they will result in the vegetations happening and so on. Is this clear? I don't get why not D. Because, okay, they're asking, like, okay, leaflet calcification and fibrosis is going to happen at the end, okay? And then they're asking what is directly involved in the pathogenesis, like something that's very specific for Streptococcus viridans. You get me? Because like in other, and like any مثلا هلا infective endocarditis with vegetations and everything, we're going to have leaflet calcification and fibrosis in almost all of them, right? But yeah, sure, I'm going to give a prayer break and like بس نخلص this question, okay? تمام. So is this question clear? Like, do you guys get why it's fibrin clot formation? Because they mentioned the Streptococcus mutans. يعني هنا لو they did not give us the pathogen, then we would just put like خلاص it's infective endocarditis, and we would put calcification and fibrosis. But because they are, and they said in the question directly involved, so they're kind of trying to hint to us, and no guys, yeah, it's this. تمام, it's the dextrins. Is this clear? Oui. تمام. طب يلا ناخد 10-minute break just to pray. Okay? Sounds good. تمام. Okay, stop the recording. Let's stop the recording. Wait, do I just pause? Oh no, it's not here. Wait. Pause, stop recording. Okay. تمام. يلا. Let's move on. Okay, an autopsy of a patient's heart who recently died in a motor vehicle accident shows multiple nodular nodules near the line of closure on the ventricular side of the mitral valve leaflet. All right, these nodules are composed of immune complexes, mononuclear cells, and thrombi interwoven with fibrin strands. So, what do you think? أول شيء, guys, before we go into answering the question, what do you think this is? So it's not something that's caused by a bacteria. It's literally immune complexes deposits. What is this called? I honestly forgot. Okay. طيب عادي. So let's read the what is it called? The patients and see which one do we think our patient is. So a 54-year-old male who recently underwent dental surgery. صح ولا لا? I don't think so. Do you guys think so? Because it's not infective. Okay. A 71-year-old male with acute onset high fever and nail bed hemorrhages. No, because this is rheumatic fever and it's not caused by an infection. A 41-year-old female with a facial rash and non-erosive arthritis. So this is SLE. Do you guys think it's this patient? Okay. A 28-year-old HIV positive female intravenous drug user. Do you think it's D? Okay. A 60-year-old male with cardiobacterium hominis bacteremia. They're literally saying أنه عنده infection. فأكيد لا. A 6-year-old female with subcutaneous nodules and erythema marginatum. This is كمان لا, because what is this, guys? The subcutaneous nodules and erythema marginatum. This is rheumatic fever. So which one? يعني the only choice that is not infective but rather caused by an immune disease. It's something that you said, guys, no. Okay, we have a D. Do you guys agree, D? But don't you guys think D is كمان infective? Like intravenous drug users, it's gonna be caused by staphylococcus. Or كمان she's HIV positive. It could be something else. It could be like, hey. Yeah, it is C. So basically, it's SLE. It's limb man sac endocarditis, and it's associated most commonly with SLE. Do you guys remember this? The non-bacterial, basically, vegetations. Okay. So even if you guys forgot in the exam, try to like a question, it says immune. So you can look for anything that gives you like a kind of idea and oh, it's an immune process, not an infective process. حتى لو مثلا ما عرفتوا إنه like this like facial rash and non-erosive arthritis إنه this is SLE. Like if you guys couldn't know this is SLE, we kind of removed everything else that's that's infective. So the only choice that we had is C. تمام? Okay, يلا. A 60-year-old man comes to the emergency department because of a 1-week history of difficulty breathing. He has recurrent palpitations over the past 2 years. During this time, he has also had several episodes of anxiety despite no change in his daily life. He has occasional sharp chest pain, okay, localized to the left upper sternal border. And he has no abdominal pain or leg swelling. He took penicillin because he had a streptococcal pharyngitis. تمام? Physical examination shows a 3 out of 6 holosystolic murmur that is the loudest at the apex and it radiates to the axilla with a mid-systolic click. So what do you guys think the answer is? So mid systolic click. Guys, what is the pathology that's associated with mid systolic? Okay, so we have C, calcific valve degeneration. No. So قولوا لي قبل ما تجاوبوا, what is the thing that's very very associated with mid systolic click? What do we have? What is the pathology? It's something in the اصلا حتى the place, it's at the apex and radiates the axilla, so it's the mitral valve. طيب شو بو mitral valve? Stenosis. Do you think it's stenosis? طيب okay, mitral valve stenosis. طيب mitral valve stenosis in an old man, what would the cause be? بصراحة أنا I'll tell you something, I don't think it's the mid-systolic click is not stenosis. It's MVP, I think. Exactly, it is MVP. Because you remember the click, what is the click? The click is the chordae tendineae tensing. So the mitral valve prolapse during the systole, the mitral valve, okay, so we have a systole, and then the mitral valve mid-systole is gonna, the chordae tendineae are gonna tense, so you're gonna hear the click. So mitral valve prolapse is the mid-systolic click. تمام؟ طيب, mitral valve prolapse in an old man, what can the cause be? Hello, guys. Can it be age? طيب, if it's age, so what do we call that? Yani, what is something that's associated with age? Shall I show you guys the answer? It's myxomatous valve degeneration. So myxomatous usually happens as yani, the age goes on. You get me? So it's not calcific valve degeneration, because calcific valve degeneration, we're going to have mitral stenosis. It's not going to be, the valve is going to be calcified. We're not going to have the mid-systolic click, which is basically the prolapse. Is this clear, guys? Or was it like... Yeah, now it is. Okay, perfect. تمام. Okay. A 75-year-old man is brought to the emergency department 20 minutes after he lost consciousness. He was playing with his 3-year-old granddaughter when he suddenly collapsed and was unresponsive for 1 minute. He responded normally after regaining consciousness. He has episodes of mild chest pain and abdominal discomfort for the past 2 months, especially while working on his car. He has hypertension treated with hydrochlorothiazide. He's alert. His temperature is normal. His pulse is normal. His blood pressure is a bit decreased. He has a grade 3 out of 6 late systolic murmur. Okay? At the right sternal border that radiates the carotids. What do you guys think this is? Late systolic murmur. And he lost consciousness. D. Do you guys agree? D? Okay. You guys are right. So because he's old, حيصير في عنا calcification. And the syncope and angina and all of these are giving like signs and it's aortic stenosis. تمام? Aortic stenosis in an old guy, it's because of the calcification of the aortic valve. Slay, guys. تمام. A 9-year-old girl, so she's young, okay, is brought to the physician by her father because of abnormal movements of her limbs for the 4 days. She has involuntary non-rhythmic movements of her arms and legs. What do we guys call this? Chorea. صح. The symptoms are worse when she's agitated, and she rarely experiences them while sleeping. During this period, she became increasingly irritable and has episodes of inappropriate crying. She has a sore throat 5 weeks. She had a sore throat 5 weeks ago, and now she just has those abruptal purposeless movement, which is the chorea that we talked about. Muscle strength and muscle tone are decreased. Deep tendon reflexes are 2+ bilaterally, so they're decreased. She has a wide-based and unsteady gait. Blah 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 blah. So her grip increases and decreases continuously. So it comes and goes, comes and goes. Okay. So what do you guys think? So we have chorea, Sinham chorea, and we have a history of sore throat 5 weeks ago. So what do you guys think is this? Oh, actually, what's the diagnosis? Rheumatic heart disease. حلو. Or rheumatic fever. طيب. What is the pathogenesis of rheumatic heart disease? Like, why do we have rheumatic heart disease? Because the pathogenesis will help us answer the question. So in rheumatic heart disease, we have antibodies against what? I gave you the answer. M protein, exactly. So this girl is having antibody cross-reactivity where, because she had a strep like she had a group A streptococcal infection, there was an basically antibody cross-reactivity to the M protein, and that's why she's having the chorea with a history of sore throat. So she has acute rheumatic fever. Tamam? Okay. Let's move on. A 50-year-old man comes to the physician for the evaluation of recurrent palpitations and feeling of pressure in the chest for the past 6 months. He also reports shortness of breath when walking several blocks or while going upstairs. There is no personal or family history of serious illness. He does not smoke. He has a 30-year history of drinking 7 to 10 beers daily. His temperature is normal. Pulse is pulse is elevated. So I know tachycardic, respirations are normal, blood pressure is a little bit high, pulse oximetry shows oxygen saturation of 92, a little bit decreased, and we have jugular venous pulsation 9 centimeter above the sternal angle, so it's elevated. So we have jugular venous distension, all right? Crackles are heard at both lung bases. We have an S3 gallop and displaced point of maximum impulse. There is spitting edema below the knees. Which of the following is the most appropriate step in the management of the underlying cause of the patient's current condition? What do you guys think the patient has? So we have jugular veins are distended. There is an S3 gallop. Do you guys know what an S3 gallop is, or what is an S3 يعني? Why do we hear the S3? And we have displaced point of maximum impulse. طيب هل انتم ما عم تردوا فانا I'll explain. So jugular venous distension, why? So you have to think انه نحن عنا the left side there is then you have dysfunction and it's causing the blood to pull back. Right heart failure. Right heart failure. Okay. هو أكيد the patient has heart failure. But why do you guys think we have heart failure? Alcohol is directly associated with which cardiomyopathy? Dilated. Okay. And in here we have all the symptoms of dilated because we have an S3 gallop. Okay. We have displaced maximum impulse. يعني the left ventricle is dilated and the apex is no longer at the fifth intercostal space, but rather down or maybe up حتى. They said displaced. They did not mention where. And we have jugular venous pulsation. Why? Because the blood is pulling back. So if someone is having a lot of alcohol and he's having dilated cardiomyopathy, what would we tell him to do? Stop the alcohol. Exactly. So how would we manage this patient? We would, first of all, do abstinence from alcohol. Hello? So alcohol is going to cause the dilated cardiomyopathy. And I know guys, this is management, but I want you guys to be able to pick up dilated cardiomyopathy from whatever they said. فthey said palpitations, they said انه general jugular venous pressure is elevated or عندنا distension. All right, there's an S3 gallop, we have the maximum impulse is no longer at its place, and we have edema. For all of these things are pointing to what? Okay, dilated cardiomyopathy. Is this clear? In your lecture, it was mentioned no alcohol and I think smoking are directly like there are risk factors for dilated cardiomyopathy. Am I right? Yeah. Come on. So Anna, a 34-year-old woman, gravida 2, para 2, is admitted to the hospital because, so she's pregnant. Gravida 2, para 2 means she's pregnant. To the hospital because of shortness of breath and fatigue 2 weeks after delivery of a full-term newborn. Okay? She has no history of major medical illness. Cardiac examination on admission shows an S3 gallop, a grade 2 out of 6 holosystolic murmur heard best at the apex, and the treatment was started. What do you guys think is the cause of, like, what do you guys think this is? So she's pregnant and now she's having symptoms. Isn't she and gave birth to them? Yeah, she was, yeah, gravida 2, para 2 means انه she was pregnant twice and gave twice. بس هي she يعني now she came back no, she's not pregnant again. I'm sorry. بس أنا كان قصدي إنه gravida 2, para 2 means she was pregnant and then 2 weeks after she delivered, she has those symptoms. So this is, someone said A, mitral annular dilation. Do you guys agree? This is cardiomyopathy due to pregnancy. And what kind of cardiomyopathy happens after pregnancy? A. صح. So it's dilated cardiomyopathy. تمام? This is called peripartum cardiomyopathy, which is dilated cardiomyopathy. I just wanted you to guys know peripartum cardiomyopathy equals dilated cardiomyopathy. تمام? So if you see a pregnant lady or like a lady who gave birth, actually she's not pregnant, like a lady who already gave birth and she arrives soon after giving birth with symptoms of the heart, just know it's dilated cardiomyopathy. تمام? Is it clear? Okay, perfect. Yalla. A 27-year-old woman comes to the physician because of a 1-year history of progressive shortness of breath. She is now unable to jog more than 10 minutes without stopping to catch her breath. Cardiac examination shows a harsh systolic crescendo-decrescendo murmur, best heard at the left sternal border. So we have progressive shortness of breath and a crescendo-decrescendo murmur. The murmur increases in intensity when she moves from a squatting to a standing position and decreases when she clenches her fist. Do you guys know what maneuver is this? Or do you guys not know that? If you don't know it, maybe the doctor did not mention it, but it's, I know this, but I forgot. طيب. Okay. No need to tell me what maneuver. What is this disease? So she's young, she has shortness of breath, crescendo decrescendo murmur, coarctation. No, because in coarctation of the aorta, it's like, how can I say it? She's gonna feel dizzy, maybe. بيكون في عنا decreased pulse. It's not gonna be just shortness of breath and a crescendo decrescendo murmur. Left sternal border. So we're talking about something in the left part of the heart. Aortic stenosis. Okay. Okay. طيب. Okay. Aortic. هل هو it's not aortic stenosis. Okay. Wait. Regurgitation. طيب guys, listen. Now we're going in a different way. This is a cardiomyopathy. Hello. This patient is having shortness of breath when she runs. So if you think of it, the heart is not pumping enough blood. Or basically it's not pumping, like it is pumping blood, but not the amount that we need. So, and she's young and they're asking about a mutation. What kind of what is it called? Not mutation, a defect. what kind of cardiomyopathy do you guys think she has? Septal hypertrophic, yes, hypertrophic cardiomyopathy, صح. طيب, this is basically the murmur that increases in intensity when she moves from a squatting to a standing position. Basically, this is the Valsalva maneuver, okay? So in hypertrophic cardiomyopathy, people that do the intensity of the murmur is going to change, okay, with the Valsalva maneuver. So you guys are saying C. Do you guys agree? The defect is in the myosin heavy chain? Perfect. Come on. Did you guys understand like why? Or was it confusing? Yes, I think we just need to review. Okay, perfect. تمام. فيعني here the idea is, and it's really important, why is this related to hypertrophic? Okay, I'll explain why. So in hypertrophic cardiomyopathy, what happens is the interventricular septum, what will it do? It will hypertrophy, right? It's going to decrease the area of the left ventricle. We were not going to be able to provide enough blood to like we're going to have the LVOT, or the left ventricular outflow tract obstruction. Why is there this obstruction? Because of the hypertrophy of the wall of the interventricular septum. So this is going to cause the following, like the progressive shortness of breath. Like she's running, and when you run, you need like a lot of blood to be pumped everywhere. صح? But this is going to cause shortness of breath because the blood is not moving as fast as we want, and we're not having enough blood because of the hypertrophy. It's not accommodating as much blood as it used to. All right? And the harsh systolic crescendo decrescendo murmur is basically it just shows that there's an obstruction, okay? Like there is the left ventricular outflow tract is obstructed, so that's why we have the murmur that we hear. Do you get me? Is it clear? So the valve itself is not affected. The murmur is not because of a valve pathology, but rather the hypertrophy of the interventricular septum is kind of obstructing, فبصير في عنا the crescendo decrescendo murmur. تمام? And هلا here صراحة guys, I'm not sure if the doctor mentioned it, but the Valsalva maneuver, okay, and the Valsalva maneuver and the clenching of the fist, if you guys saw something like that, directly know it's related to hypertrophic cardiomyopathy. تمام? Plus the patient was fairly young, 27 is really young. So you can kind of take it as a hint. You get me? تمام. I hope I covered everything, guys. I hope it's clear. If you guys have any questions, عادي ask. تمام? Okay. Let's move on. Okay, a 16-year-old boy is brought to the emergency department. شو اسمه? 20 minutes after collapsing while playing basketball. There's no personal or family history of serious illness. On arrival, there's no palpable pulse and no respiratory effort is seen. He's declared dead. The family agrees to an autopsy. What would you guys see? So نفس الشيء. He was playing basketball, something that needs a lot of oxygen, and then he collapsed and he died. Okay? If we do an autopsy in the heart, he's fairly young. So what would it be? I just said it to you guys. It's kind of obvious. Septum. So G. Do you guys agree? Yep, it is G. So hypertrophic obstructive cardiomyopathy is, or hypertrophic cardiomyopathy is like one of the most common causes of sudden cardiac death in athletes, specifically young people. تمام? So if you see a young patient that, if you see in the clinical vignette or like in the question, they're saying, oh, like a very young patient is playing basketball or he's running or whatever, and then he started he like passed out, or he started having the shortness of breath like we mentioned before, just think of hypertrophic cardiomyopathy. حلو? خلاص, clear? Okay. تمام. A 70-year-old man comes to the physician because of a 2-month history of shortness of breath and leg swelling. تمام. He has trouble climbing one flight of stairs due to dyspnea. He has hypertension and was diagnosed with multiple myeloma 6 months ago. So what does he have? He has multiple myeloma. Current medication include hydrochlorothiazide. Cardiopulmonary examination shows regular venous distension, bibasilar crackles, and pitting edema in the lower extremity. And then we see a thickened myocardium. Sorry. A thickened myocardium with basically elevated diastolic filling pressures. What do you guys think it is? Someone said C. Do you guys agree? طب why? What's something in the question that يعني خلاص once you see it you're like amyloid can lead to hypertrophy. Myeloma. Exactly, the myeloma. So we see multiple myeloma, we directly think of amyloid deposition. So it's basically, it doesn't cause hypertrophy, it rather causes restrictive cardiomyopathy. Why? Because the amyloid plaques are being deposited. فبصير في عنا restriction. Okay? لا يعني amyloid is gonna cause restrictive cardiomyopathy. Is this clear? Well, specifically, like when you see multiple myeloma, just know, like, oh my god, multiple myeloma, خلاص, directly, amyloid deposition. So we're going to have restrictive cardiomyopathy. Okay? Okay. Now we kind of finished with cardio. Okay. At the end, I have a couple of questions come on about cardio. Now we're going to pulmo. Are you guys ready? No. صراحة same. Okay. Let's read. Do you want me to read or is it just long وحط lines and you guys see like the most important things ويلا مشان نخلص بسرعة ولا I think reading is better, but what do you guys think? Am I reading too fast? Nope, yes. Either works with me. خلاص I'll read. But I'll read a bit شوي يعني slower. طيب, a 68-year-old man comes to the physician for a routine health maintenance examination. He has increasing shortness of breath and a productive cough for the past year. حلو? So عندنا shortness of breath and a productive cough. He can walk up a flight of stairs without stopping. He has hypertension and his only medication is amlodipine. He has a history of asthma during childhood. He used to work as a shipyard and retired 5 years ago. He smoked 1 pack of cigarette daily for 30 years, but he quit 16 years ago. His pulse is 98 normal, respiration is elevated, blood pressure is high, pulse oximetry on room air shows oxygen of 93. We have scattered expiratory wheezing. We have rhonchi, and we can see that the spirometry shows 63% the FEV1 to FVC ratio, and FEV1 is 65% of predicted. And if we look at the diffusing capacity, it's command decreased. So first of all, what kind of what is it called? What kind of obstructive? حلو. Okay, obstructive. Obstructive معناتها it's not, obviously it's not asthma. Like, okay, asthma is kind of obstructive, but no, it's not asthma. Like these symptoms don't give asthma. Everyone is saying B. طب why B? ليش chronic bronchitis مو مثلا emphysema? And asthma eventually leads to chronic bronchitis. Okay. Cough for 3 months. Okay. الquestion الانسر حيصدمكم صراحة. So it's emphysema. Okay. I expected you guys will tell me, it's chronic bronchitis and why not. هلا in chronic bronchitis, okay, the productive cough is gonna be like the chronic bronchitis. It's gonna be أول شيء الcough is gonna be either it's gonna like have a color. تمام. هلا هون they didn't even mention the color. Okay, بس if you look at شو اسمه. Wait. I remember the doctor said emphysema, no productive cough. طب okay, listen. If the doctor said emphysema, no productive cough, then ignore this question. خلاص, we can just move on. بس لأنه هو when I did the hay, they said that no, emphysema has a cough, okay, but usually it's gonna either be like the clear productive cough. It's not gonna be like, you know, chronic bronchitis. You'd imagine it has like it's like green or yellow. You get me? Well, green or yellow is infection. صح, معكم حق. ما بعرف أنا هيك كان كاتب أمبس صراحة. ف I don't know if أمبس is a reliable source. No, don't guys, don't get scared. Okay? Don't get scared. We can just ignore this question. I can go and like read more about it. بس أنا صراحة when I did the question, I كمان and I was like, why is it not chronic bronchitis? But I think it has to do كمان with DLCO. I'm not sure. Let's ignore this question for now and move on وبنرجع له. Yeah, خلاص, we appealed the question. Yeah, if you guys get such a question, just appeal it. Okay, تمام. طيب خلاص guys, don't be scared. أنا خفت إني خوفتكم معي. Just ignore it, okay? Bye bye. It never existed. I'll double check guys واشرح لكم. Like I'll send a message and say why it was emphysema. And if I found the reason not to be really like, I'll check the lecture كمان. If the doctor said no productive cough, then خلص, just stick to whatever the doctor said, okay? Because sometimes يعني the like the other sources are kind of they get like extra stuff or high like a higher level stuff. Anyways, let's move on. Okay. A 44-year-old man comes to the physician because of a 5-month history of persistent cough productive of thick yellow sputum and worsening shortness of breath. 1 year ago, he had similar symptoms that lasted 4 months. He has smoked 2 packs of cigarettes daily for the past 20 years. Physical exam shows scattered expiratory wheezing and bronchi throughout both lung fields. Okay, so we have wheezing, we have cough productive of thick yellow sputum and worsening shortness of breath. So what do you guys think? Increased goblet cells, okay, more mucus. It makes sense. It is E, صح. But you see guys, chronic bronchitis in here, they're saying إنه it caused the yellow green color. That's why I'm telling you, like, hey, can an explanation on what is it called? On ambas. I'm not really sure. Let me just go some wait 1 second. In here the scenario, a productive cough for the past year. Let's see here. A productive cough for 5 months. Has nothing to do with that. خلاص guys, just ignore the other question. تمام? Is this clear? بدي الكل يكتب لي clear. Okay. تمام. A 36-year-old woman comes to the physician because of a 3-month history of intermittent cough, productive of thick yellow phlegm and increasing shortness of breath. Okay, so again, we have productive thick yellow phlegm and increasing shortness of breath. She especially becomes short of breath while playing with her children. She has worked as a farmer for 18 years. She has asthma treated with salbutamol inhaler. She has smoked half a pack of cigarettes. Scattered wheezing and decreased breath sounds are heard throughout both lung fields. Cardiac examination shows no abnormalities. The abdomen is soft and non-distended. The liver is palpable. So عندنا a problem in the lungs and the liver. So what do you guys think? وطبعا FEV1 and FEV1 to FVC ratio is decreased. FEV1 is decreased. So عندنا obstructive. A. صح. هلا I understand, yeah, it might show earlier, but because it's a genetic disease, يعني there's polymorphism. فيعني maybe some people it won't be as like you get me, like it won't be as strong لحتى انه it shows early in the disease. Don't take it انه like, oh, is a case is early in the in age that it's alpha 1 antitrypsin. No, it might be later on. You get me? بس أهم شيء in alpha 1 antitrypsin, if the lung and the liver are affected, خلاص, it's alpha 1 antitrypsin. Yeah, it's so easy. Whenever you see lung, liver, alpha 1 antitrypsin. Okay? تمام. Now we're gonna play a little game. You guys are gonna hate me. A 23-year-old woman is brought to the emergency department because of a 2-hour history of shortness of breath. She has a history of atopic dermatitis. Okay? I know, guys. I'm sorry. طب هلا خلينا نشوف. She does not smoke or use drug recreationally. Her temperature is 37.1. Respirations are 28 per minute. So she's hyperventilating. She appears anxious and is unable to speak in full sentences. X-rays of the chest is shown. So you guys can see the chest. طب قولوا لي انتوا شو شايفين بالchest؟ Okay. when we look at any X-ray, something looks off with the diaphragm. Perfect. So we have flattening of the diaphragm. So what does flattening of the diaphragm mean? Okay, it doesn't matter if it's emphysema or whatever. It's chronic air trapping. Okay, air trapping. It's obstructive disease. Okay, for obstructive disease, we have a lot of air inside. So if we auscultate, air is trapped. Would we hear decreased breath sounds or increased breath sounds? Or what would we hear? Let's go one by one, just auscultation. The air is trapped inside. So we're not hearing the air go in. So we're not hearing breathing. So what do you guys think? Would it be decreased? Is the white tissue over the yeah, it is just the breast tissue. Guys, I think I included a photo بس أنا خايفة إنه تكون اللي حاطة ورا answer not the photo. Wait, I'll stop sharing for a second. No, you know what? Okay, never mind. You guys saw it, but let's explain. So when we auscultate the breath, exactly, we're gonna have decreased breath sounds. Why? Because the air is trapped inside. The air is not going in. Okay, so what we hear is like when we auscultate the chest, we hear E source chest. Guys, do you want to know the truth? عادي, it's okay to guess. Wallah. Sometimes your guess is we don't call it a guess. We just call it's an educated guess. You guys like guess with an educated approach. Okay. هلا خلونا نشرح الموضوع. It is E. Okay. But why is it E? Because when we auscultate the chest, as we said, air is not going to go in, so we're going to have decreased breath sounds. Okay. So decreased breath sounds, it will be ya E, ya A, ya B, ya E. Okay. Chest percussion. So do you guys know when we percuss? Okay. Usually, what do we hear? Hyper. Exactly. وعندنا هلا more air. So air is trapped in. So it's going to be hyper resonant. Slay. So now it's either B or E. Now, chest expansion, would it be asymmetric or symmetric? Symmetric, because exactly, we don't have any chest wall like deformity, or we don't have flail chest. We don't have any lesion, you know, like we don't have any pathology that would cause the chest expansion to not be symmetric. And exactly, the trachea is symmetric, and basically we don't have like مثلا pneumothorax, hemothorax, or like whatever. We don't have anything. It's just literally the air is trapped in. With tactile firmitus, do you guys know what tactile firmitus is? Vibration. Okay, so vibration, is it, where is it higher? 99, exactly 99. So tactile firmitus, do you think it would be increased or decreased? هلا keep in mind إنه vibration goes the fastest through what? Through solids ولا air? Solid. So basically the tactile firmitus will be decreased. Exactly. So it was E. شفتوا guys, it's not hard. Just have to like think. You guys are gonna kill me, but yeah. You know, I wanted to include more questions with arrows, but I was really scared that you guys would kill me. But I did not. I think this is the only one that's like that. You know, guys, in your step one exam later on, inshallah, you're gonna have like questions where they're like up, down, decrease, increase. So يعني عادي. I feel like get used to it early on. All this just to get recall questions in exam. Step one is a problem. يعني صراحة, yeah, it is. It is a proper problem for future you. Um, you never know. هو صراحة إن شاء الله you get recall questions. Like I really hope, guys, your exam goes really smoothly. But if you guys understand these things now, I don't know where, but it will help you. You get me? Like I think it can. We're 260 students in total. Filtering. Yeah. Welcome to Al Faisal. I don't know what to say. But صدقوني, guys, the exam's gonna be fine. And I feel like 260, they're not gonna filter much. Right? Reem, please don't minimize. Guys, it's gonna be okay. Okay, والله صدقوني. خلاص انتوا شفتوا كيف you're like guys learning here? It's okay. تمام؟ يلا, let's move on. Guys, the image is really clear. يعني أنا ما حأقرأ. إذا عرفتوا من الimage, bronchiectasis. Okay. So, do you really think it's bronchiectasis? Okay, now I think I really have to read. But you're right. So which one of these? Actually, bronchiectasis. Good question. طب خلاص خلينا نقرأ. A 47-year-old man comes to the physician because of a 7-week history of cough, shortness of breath, and daily copious sputum production. He has had frequent respiratory tract infections. Current medication include dextromethorphan and guaifenesin as needed. He does not smoke cigarettes. His temperature is 37.1. Diffuse crackles and wheezing are heard on auscultation throughout the lung fields. CT scan is shown. What do you guys think? We have A. طيب, A. It is correct. A. But why is it A? What is this guy having? Like he has frequent respiratory tract infections. None of the other makes sense. Yeah, you're right. But he's having frequent respiratory tract infection. هن ما حددوا لكم الأشياء الثانية اللي he has. But if someone presented with frequent respiratory tract infections, what is a disease that you think of? Yalla guys, it's easy. Cartagner syndrome, cystic fibrosis. Cartagner syndrome, like, you're right, but Cartagner syndrome is basically when you have ciliary dysfunction of the, basically the, you get me, like the tract, the airway. But in Cartagner syndrome, yes, usually you have dextrocardia, and in here it's normal. Like if you look at this heart is normal. It would not be Cartagner, you get me? But it is cystic fibrosis. So you guys see, like we have like you see how the bronchi, they're really like wide. They're widely open. But you can see the bronchi are being damaged. So that's why the answer is A. Okay. And wait. And Afan, you were right. It is bronchiectasis. Is this clear? طبعا the cystic fibrosis question I'm asking just يعني as a general information. I didn't mean إنه this is cystic fibrosis, okay? Plus شايفين هدول like this is called honeycomb appearance. فإن honeycomb appearance, you can see like they look like rings. Like they're widely open. تمام? Let's move on. Okay, a 4-year-old boy is brought to the physician because of frequent respiratory tract infections and chronic diarrhea. I give you the answer. His stools are bulky and greasy, and he has about 8 bowel movements daily. He's at the 10th percentile for height and 25th percentile for weight. Chest examination shows intercostal retractions along with diffuse wheezing and expiratory rhonchi. Which of the following is most likely the cause of his condition? So what is this condition? We have diarrhea with it and bulky and greasy bowel movements. Motil celi. Guys, cystic fibrosis, doesn't it usually have like a pancreatic insufficiency? That's why we have bulky and greasy bowel movements. صح ولا لا? Or did you guys not take this? Hello? Okay. So هلا, this question is cystic fibrosis. Okay? It's okay. So, cystic fibrosis, okay? هلا, Cartagner syndrome is celiac dysfunction. So I would understand why you would say it's B, because defective ciliary protein function is Cartagner syndrome. In Cartagner syndrome, usually will have basically respiratory tract infections. We're gonna have dextrocardia. We're gonna have infertility. But in cystic fibrosis, okay, usually we have pancreatic insufficiency. تمام؟ فلأنه عندنا pancreatic insufficiency, the patients are not gonna, they're usually not gonna absorb the, you know how the pancreas secretes lipase? So the lipase is there to break down lipids, صح? فإذا lipase is not secreted, what happens? The stools are going to be bulky and greasy. So when we see إنه عندنا chronic diarrhea, bulky and greasy, and respiratory tract infections, we think of cystic fibrosis. فهلا أنا قلت لكم إنه it's cystic fibrosis. What is the problem in cystic fibrosis? What happens? CFTR mutation. Perfect. Increased mucus. صح. طيب. Let's go through the options. Increased frequency of trinucleotide repeats. No, we don't know what the hell this is. This is something genetic that this has nothing to do with cystic fibrosis. Okay, I know no cystic fibrosis is a genetic disease, but this specifically is something else that you guys are gonna take later on. يعني مثل Huntington, like something neuro. Okay, so it's not A. تمام. Defective ciliary protein function. We said it's not Cartagner, so it's not B. Intracellular retention of misfolded proteins. Do you think this is the answer? طب wait, قبل ما نكمل. D, altered configuration of a protease inhibitor. This is alpha 1 antitrypsin. But doesn't the increased mucus and pericelia or no? هلا, you're right. But نحن we're talking about specifically cystic fibrosis. Cystic fibrosis, we don't have a ciliary protein dysfunction. We have, you said, عندنا CFTR mutation. This CFTR mutation would cause misfolded proteins to be to be inside the cells. So that's why all the dysfunction happens. So the answer is C. تمام? So we have a chloride channel dysfunction, and because of the mutation or the deletion of the basically the CFTR gene, بصير في عنا misfolded, the protein that is formed is going to be misfolded. So it's not going to be able to leave the cell, but it's going to accumulate inside the cell. And this is what will cause the following. عرفتي علي؟ هلا guys, أنا شفت إنه the doctor mentioned cystic fibrosis. I don't know if he went into these details. If he did not, then خلاص انسوا. But this is very basic. يعني cystic fibrosis equals intracellular retention of misfolded proteins. This is like the basic. تمام؟ فاeven if مثلا the doctor did not mention, just know it. If it's too much, just خلاص. Never mind this question. Okay? يلا, moving on. A 55-year-old woman comes to the physician because of an 8-month history of persistent dry cough and shortness of breath with mild exertion. So عندنا dry cough and shortness of breath. Okay? She reports feeling too weak to leave the house on most days. She has rheumatoid arthritis and hypertension. This is clearly F. You're right. So عندنا enlargement of the fingertips with increased curving of the nails and bilaterally enlarged metacarpopharyngeal joints, and we have inspiratory crackles. طيب guys, but tell me, what is enlargement of the fingertips? What is this called? Clubbing. Exactly. So عندنا clubbing, عندنا عندنا she has an immune disease. It's gonna be, and you can see in the honeycombing, like it's so clear بالصورة. It's interstitial lung disease. تمام. وحتى dry cough. The cough is not productive. In COPD, the cough was productive. Okay. A 45-year-old man comes to the physician because of a one-year history of dry, non-productive cough. He reports worsening shortness of breath on exertion and fatigue for the past 2 months. He was a miner at nearby quarry for 10 years and is now a manager there. He has hypertension, he has asthma, he smoked, he does not drink or do drugs. He does not appear to be in acute respiratory distress, so he's fine. But when we did auscultation, we saw diffuse fine crackles over the upper lung field bilaterally. He was a minor, guys. So what do you guys think is the issue here? Obviously, it's, I think silicosis was upper lung. Okay, so I'm confused because it could be B or D. Aspergillosis. These minerals are both minors. That's true. Let's see. So we can see how it's everywhere. It's silicosis. Why is it silicosis? I'm sorry, that was my cat. No way, I thought you said asbestosis. Anyways, guys, so basically because he's a quarry worker, he inhales like crystalline silica. And one of your friends in here said that silicosis was in the upper lung. And if you guys look in here, it's not diffuse, it's mainly here. Okay? So that's why we chose silicosis. Is it clear? But Anna, I'm pretty sure in your question, the doctor is gonna kind of like make it really, really like clear إنه it's silicosis. بس إنه إذا شفتوا upper lobe nodules, okay, and a person who works in a mine or whatever, just think of silica, okay? And a way to think of this is just basically silica as like sand, and you know how sand, like if you throw it in the air, it's light, but it's gonna go like float all the way up, but it's gonna be at the upper borders. Hello? Clear? Yes, move on. I'll take this as a yes. Okay, slay. Tamam. Let's read. A 70-year-old man comes to the physician because of an intermittent shortness of breath while going upstairs and walking his dog. It began about 1 month ago and seems to be getting worse. He also developed a dry cough. So عنده dry cough intermittent shortness of breath. تمام? He has not had any wheezing, fever, chills, recent weight loss, or shortness of breath addressed. He has a history of Hodgkin lymphoma. Blah 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 blah. He took radiation. He has hypertension. He has treated hypertension. 10 years ago, he used to work in a shipbuilding industry. He has smoked half a pack of cigarettes daily since the age of 21. On auscultation, there is mild basilar crackles. A plain X-ray of the throat shows bilateral ground glass opacities of the lung bases and bilateral calcified pleural plaques. صح, guys, it is asbestosis because of occupational exposure. Slay, guys. طبعا ground glass opacities is extremely high yield for asbestosis, okay? So again, for silica, قلنا إنه they're gonna involve the upper nodules. Like we're gonna see haziness, it's gonna like float around. In asbestosis, we're gonna see ground glass opacities. تمام? Clear? Let's move on. Okay. A 60-year-old man comes to the office because of a 6-month history of worsening shortness of breath, abdominal discomfort, and swelling of his legs. Okay? He does not have fever, chills, or chest pain, but he has a cough and occasional episodes of dyspnea during the past 4 years, but has not seen a physician for 15 years. Wow. He smoked 1 pack of cigarettes daily for 30 years. Okay? And he appears fatigued. He drinks, obviously, and then his pulse is normal, respiration is increased, blood pressure is high, oxygen saturation is low, cardiac discloses distant heart sounds, and right peristernal heave. A or C. There is jugular venous distension, and we have diffuse expiratory wheezes, the liver edge is palpated, abdominal fluid wave is present, there's spitting edema. The remainder of the examination shows no abnormalities. No, see me, thanks. It is C, guys, صح. So basically عنا, what do we have? We have corpulmonal, because the chronic pulmonary hypertension is going to cause right-sided heart failure. And if we look at everything he's going, we have congestion, صح? We have jugular venous distension, okay? So the jugulars are like distended and everything. Why do we have hepatomegaly? Because of the distension, like the blood is not moving to the left side, right heart failure, exactly. For right heart failure, usually not usually, but it can be caused by chronic pulmonary hypertension, and he's already having let's go back. He's having cough and occasional episodes of dyspnea, so it's showing us that, oh, the lungs are affected. Okay, it's clear, it's easy, you guys knew it. Slay. Okay. A 33-year-old woman comes to the physician because of a three-week history of fatigue and shortness of breath. Okay? There is no family history of serious illness. She does not smoke. She takes diethylpropione to control her appetite. Okay? And she has a 4.5 kilogram weight loss during the past 5 months. Tamam? She's 163, weights whatever. Cardiac examination shows a loud pulmonary component of the S2. Abdominal examination shows no abnormalities. Which of the following is the most likely cause of the patient's shortness of breath? So we have worsening shortness of breath. تمام؟ عندنا fatigue. وعندنا a loud pulmonary component of the S2. So what do you guys think this is? هلا F classification of the pulmonary valve. Does everyone agree? Because load S2 F. Or C. Like, okay. It's okay, guys. Listen. هلا انتوا to answer this question you had to know انه diethylpropione is a sympathomimetic, so maybe that's why it's fine, like انه it's a toxicity caused by this medication. بس هو the prominent S2 doesn't only mean I'm sorry, just forget the sympathomimetic. بس انه the loud S2 is not only pulmonic valve, it can include anything that has to do with the lungs. تمام. هلا نحن هون if we look at the fatigue and the worsening shortness of breath. خلاص, you know what, guys, appeal this question, never mind it. صراحة أنا I thought I saw the pulmonary arterial hypertension and I wanted to do that, but oops, forget this question. Mom, don't be scared. What you guys said for the pulmonary valve classification because of S2 is correct. Don't worry. Mom, you guys hate me? I think you do. I'm sorry. Just forget that question, okay? But you guys were right. Pulmonic valve. I hate CVP. No, guys, never mind. Wallah, that question is my mistake. Like, actually. I like when preparing, I just looked at the pulmonary arterial hypertension. I didn't see the drug caused the pulmonary arterial hypertension. But you guys know what pulmonary arterial hypertension is, right? How many more slides do we have? Let me check. Like, not much, I think. And sure. We have like 30 slides left. Yani 15 questions, let's say. Is it okay? So, yes, guys, it's okay. Forget that question. Let's move on. Forget whatever happened. Tamam, yalla. Let's work together. 3 days ago, after undergoing an open cholecystectomy, a 57-year-old woman has fever, chills, and headache. She has right-sided chest pain that increases on inspiration, and she has a productive cough for the last 12 hours. Okay? She had an episode of hypotension after the operation that resolved with intravenous fluid therapy. She underwent an abdominal hysterectomy 16 years ago for multiple blah, 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 blah. Guys, it's just like a bunch of things. Ignore these. أهم شيء عنا fever, chills, and a headache. Side عندنا right-sided chest pain and the productive cough. عندنا inspiratory crackles are heard at the right lung base. Okay? Never mind, guys. Anyways, okay. So she went through a surgery. After the surgery, she has fever, chills, and a headache. تمام? And she has right-sided chest pain and a productive cough. And we have inspiratory crackles that are heard at the right lung. What do you guys think this is? Okay, Afan, I know everyone saw the answer, but the idea is إنه نحن we have surgery. So she is staying in the hospital, صح? Because so if she is staying in the hospital, she has fever, she has a productive cough, and she has chest pain. What do we think of? An infection, right? يعني أكيد it's not going to be congestive heart failure because congestive heart failure takes time for it to happen. فأكيد not A. Pulmonary embolism is not gonna it's gonna show with shortness of breath. It's not gonna like a PE is not gonna have fever, and it's gonna show in a different way. We're not gonna have crackles and stuff like that. Subphrenic abscess, whatever. We don't care about that. Pneumothorax, no, because why do we have fever and chills? صح? So the only thing that makes sense is pneumonia. So this is post-operative pneumonia or hospital-acquired pneumonia. Do you guys remember yesterday we said, no, how do we treat hospital-acquired pneumonia? Yalla, what are the 3 drugs? Or actually, they're 2. Were they 2? No, they're 3. Yalla, I want to see if you guys were like focusing with me like yesterday. Or even if you didn't, do you guys know how to treat hospital-acquired pneumonia? So what are the organisms that cause hospital-acquired pneumonia? Compound therapy, obviously it is compound therapy, yeah. What is it made up of? So now we're targeting which two main organisms we're trying to kill them. Okay, vancomycin. Yes, vancomycin. We're trying to kill what? Or like prophylactic protection from what? From Staph aureus MRSA. صح. Other than vancomycin, we have another organism that we need to protect the patient from. What is that? Yalla, fast. Yalla, guys. Okay, fine. Epidermidis? No. It's Pseudomonas. So we're trying to protect the patient from Pseudomonas. What do we give for Pseudomonas? Okay, خلاص, it's fine. Levo. Usually, I'm not sure of Levo, but we give piperacillin and tazobactam to protect from gram-negative and from Pseudomonas, and then we give vancomycin for MRSA. تمام؟ يلا عادي, guys, it's fine. Just keep it in mind because you never know what they might ask. Let's go. A 73-year-old man is brought to the emergency because of fever, malaise, dyspnea, and productive cough with purulent sputum for the past day. So we have fever, we have productive cough, and we have sputum. His temperature is high, fever. The pulmonary examination shows crackles over the right upper lung field. Okay? The sputum ground stain shows a gram-positive cocci. Despite the appropriate treatment, the patient dies 5 days later. An autopsy shows gross examination shows that the right lung has a pale grayish-brown appearance and a firm consistency. So microscopic examination of the tissue is most likely to show which of the following. So which stage are we in the pneumonia stage, guys? Lobar pneumonia. Remember, lobar pneumonia has like 5 stages. Gray hepatization. Slay. صح. So gray hepatization. How will it show? Someone said the A. Do you guys agree? Yes, exactly. So gray hepatization, we're going to have fibrinopurulent leukocyte exudates and lysed erythrocytes. Tamam. Yalla. A 32-year-old man who recently emigrated from Somalia came to the physician because of a 4-week history of fever, cough, and chest pain. He had a 5-kilogram weight loss over the last 3 months, and despite no changes in appetite, his temperature is 38.1. Physical examination shows enlarged cervical lymph nodes. The lungs are clear to auscultation. The results of an interferon gamma release assay are positive. An X-ray of the chest shows a bilateral mediastinal lymphadenopathy. A transbronchial needle aspiration biopsy of a mediastinal lymph node is performed. A micrograph of the specimen is shown. This structure right here, what is this, guys? This is a granuloma that is caused by TB, صح? Do we agree on this? Because everything is saying TB. He came from Somalia, which is basically an endemic place for TB, and a fever, cough, chest pain. We have interferon gamma release assay positive, bilateral mediastinal lymphadenopathy. Okay, this biopsy, what do you guys see? A granuloma. What are granulomas made of? Or like, hey, cell. It's a big cell. It has a lot of nuclei. What is it called? Do you guys know? Do you guys take this? I'm pretty sure you did, Yani. This is basic TB. Langhans giant cell. Slay! It is Langhans giant cell. طيب, Langhans giant cell. What is it made from? It's a bunch of things that are connected together. And this is the answer. So, a bunch of epithelioid cells. B, macrophages. It is macrophages. صح, guys. So basically, like the TB will result in the formation of granulomas, right? What causes the formation of granulomas, or what starts the whole process is macrophages. Is this clear? So Langhans giant cells, what are they made from? Epithelioid macrophages. Is this clear? Yes. Everyone clear? Let's move on. A 32-year-old man comes to the physician for a 1-month history of fever, chest pain, and deep breathing. Tamam? He has weight loss, his temperature is high. X-ray will show subpleural nodule in the right lower lobe with right hilar lymphadenopathy. When we did microscopic examination, we saw a bunch of granulomas with acellular cores. So what do you guys think this is? What? F, D, B, حبات ال Okay, no B. Okay. Whoever said C, not C, D and F. Why D and F? Why not B? Whoever said B, you guys are right. Because this is classic CB. He has fever, chest pain, deep breathing. He has weight loss. He has granulomas. He has hilar lymphadenopathy. But I would understand why someone would think sarcoidosis because of the bilateral higher lymphadenopathy. But in sarcoidosis, we don't have the fever, we don't have the weight loss. Maybe we might have weight loss, but the fever is kind of more of like an infection, which is TB. Tamam? And because it kind of makes sense in its primary TB because there are no any signs no it's miliary. Miliary TB means no it's all over the body, and we're only talking about respiratory like symptoms. Tamam? Okay. Oh, plus, guys, they said lower lobes. TB is known to be like to usually have like the granulomas in the lower lobes. Okay? Is this clear? خلاص, I'll move on. تمام? Yeah. Okay. Now we move to the lung cancer. Okay, I gave you the answer, guys. Never mind. A 63-year-old man comes to the physician for the evaluation of difficulty walking for the last 6 months. He reports weakness of his lower legs that improve with exercise and throughout the day. 3 months ago, he started adding flax seeds to his breakfast because he's frequently constipated. He has hypertension and type 2 diabetes. You guys are answering. Shall I? Uh, his current medications include enalapril and metformin, blah, 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 blah. He has dry mucous membranes. His muscle strength is decreased. Sensation to pinprick is normal. The reflexes are decreased. So, what kind of... Okay, everyone is saying B. You guys are right. What is this called? What is this paraneoplastic syndrome? صح, Lambert. So, it is Lambert-Eaton syndrome, and it's usually caused by small cell lung cancer. تمام? No way they'd ask this. هلا, never say never, but I think paraneoplastic syndromes are really important. Small cell is like Cushing, ACTH, ADH. Yeah. Plus this, like this is important. I know it's like myasthenia gravis. Like if you guys, but you guys, did you take myasthenia gravis? Or is it later on? Okay, it's like myasthenia gravis. Like it's literally myasthenia gravis was all over the body. And the difference أنا قلت لكم إنه it's a lung cancer. Usually they'll tell you إنه like in the exam the doctor will tell you إنه oh he has a lung mass in هيك. So you'd know it's like it's this, okay? Plus أصلا if you read everything else it doesn't make sense. بس إن شاء الله they don't get you something like that. But I think paraneoplastic syndromes are important بصراحة يعني. Anyways, let's move on. A 45-year-old African-American woman comes to the physician after an episode of hemoptysis. So she's coughing up blood. Over the past 8 months, she has had a non-productive cough, fatigue, and a 9-kilogram weight loss. These are giving us cancer vibes, right? And hemoptysis and weight loss, non-productive cough. She drinks a glass of wine every night and does not smoke cigarettes. She has a history of hypertension and osteoarthritis. She doesn't take any medication, blah, 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 blah. Everything is not important. أهم شيء X-ray. It shows a 2.5 centimeter nodule with irregular borders at the apex of the left lung. And she's not a smoker, and she's a female. Which of these do you guys think it is? F. Do you guys agree? خلاص, F? Okay. صح. So the most common lung cancer in non-smokers is adenocarcinoma. فخلاص, the second you see any signs of lung cancer and the non-smoker, what type was this called? What do you mean what type? Adenocarcinoma. It has a type? Oh, you mean small paraseptal or something? No, the هلا yeah, paras انت اللي عم تحكي عن pancreas tumor. A pancreas tumor انه it can be no, pancreas tumor are tumors that are at the very very top of the lung. It's not specifically adenocarcinoma always, عرفتي؟ بس انه just know that adenocarcinoma is associated with non-smokers and it's peripherally located. So it's not beside the bronchioles, it's not beside the main stem of the hay, it's usually on the peripheries, okay? And usually more common in women. تمام, يلا. A 54-year-old man comes to the emergency because of a 3-week history of intermittent swelling of his left arm. And he's feeling fullness in his head that is exacerbated by lying down or bending over to tie his shoes. Physical examination shows left-sided facial edema and distension of superficial veins in the neck and the left chest wall. Which of the following symptoms do you think, which of the following is causing the patient's symptom? Do you think it's right heart failure? Guys? Yes? Why right heart failure? Wait, it's guys, it's swelling of it only happens, it's exacerbated by specific things, bending down, lying down. He has edema بوشه, like edema in his face and distended superficial. C, I think, apical lung tumor. Do you guys agree? Does a pancreas tumor cause that? Like if you think of it, where are pancreas tumors? Exactly, yeah, it is a pancreas tumor because pancreas tumors, they're on in هيك فوق, like at the very very top of the hair, and it can easily cause, you remember this from first year, no way. They can easily cause subclavian venous congestion. And كمان another thing that they might test you on is Horner syndrome. Like they might tell you like, oh, someone came with, let's say, with you know what Horner syndrome is, صح? Meiosis, meiosis, anhydrosis, and ptosis, right? Yeah. Meiosis, ptosis, anhydrosis. Yeah, meiosis, ptosis, anhydrosis. So basically, they'll tell you like, oh, someone came and his eye is funny, or like he can't, like his lid is like he can't move his lid, and he's like they'll just describe Horner syndrome, and they'll tell you that he had a cough, and yalla, what is it? Pancreas tumor can make sense, تمام? Okay, yalla. ما في issue, guys. I'm sorry. We're going to finish this strong. تمام? Yalla, a 58-year-old man is brought to the emergency department after a witnessed tonic-clonic seizure. He has a seizure. His wife says he has had a persistent dry cough for 6 months. During this period, he has also been fatigued and lost weight. So, fatigue, lose weight, dry cough, it's a tumor. The patient has no history of serious illness, does not take any medication. He has smoked 1 pack of cigarettes. He's a smoker. Laboratory studies shows a serum concentration of 119. So his serum concentration is decreased on a hyponatremia. Glucose concentration of 102. It's kind of elevated, I think. An X-ray shows irregular, poorly demarcated mass at the right hilum. Yuna said A. Do you guys agree? I agree. Male smoker. Yes, we do. We don't. Okay, so guys, remember perineoplastic syndromes? Didn't we say إنه عنا ACTH, SIADH, ACTH, AZH, and the Lambert-Eaton. So نحن عنا هون hyponatremia 119. So which is the one that causes most of these perineoplastic syndromes? Because actually is most common, no? Yeah. If you're talking, listen, هلا نحن إذا we remove the hyponatremia part, squamous cell lung carcinoma is the most common smoking, يعني إنه lung cancer when a patient smokes. بس نحن هون يعني the serum he has seizure and decreased sodium. You have to think of perineoplastic syndrome. فدغري you put small cell lung carcinoma. تمام؟ يعني هنا in the question they would have not talked about the sodium or the seizure if they didn't want you to like think of like small cell. Squamous also has perineoplastic syndrome. Yeah, but does it have the ADH specifically or something else? Because I think it's something else. You get me? It's, I think, the squamous cell lung carcinoma causes hypercalcemia. صح. هون نحن عم نحكي عن hyponatremia. Yeah. عرفتوا علي؟ I know, guys. هلا listen, هو دكتور شوكت اللي عطاكم the lecture, right? دكتور شوكت is a cutie. Like, I don't think the questions are gonna be hard, inshallah. بس it's important to know the perineoplastic syndromes. I really don't remember in our final how it was. بس just remember anything that has to do with ACTH, يعني Cushing syndrome, anything that has to do with something that mimics myasthenia gravis, or something that has to do with sodium, small cell lung carcinoma, because of the perineoplastic syndrome. تمام? Clear? Is it clear to everyone? Or did we lose people? No, we're losing people, but it's okay. Yalla. A 71-year-old woman comes to the physician because of a 4-month history of worsening cough and a 4.5 kilogram weight loss. She had smoked 1 pack of cigarettes daily for 35 years. Okay? She has physical examination, shows wheezing, and serum calcium concentration is increased. Yalla, what's the answer? Hala, it's clear. E صح. Ta-da! Exactly. So, squamous cell lung carcinoma is the most common type of lung cancer in smokers, and it usually has paraneoplastic syndrome associated with hypercalcemia. Slay. Oh, guys, squamous cell carcinoma it releases the PTHRP. Do you know it? اللي هي it stimulates the parathyroid. It's like a mimicker parathyroid hormone. Yeah. So that's why we have hypercalcemia. If I remember this. You know, they might مثلا mention إنه oh like his PTH is low but عنده PTHRP. I don't know if they would do that. Like I don't think they're mean like that. بس يعني keep it in mind, you know? إن شاء الله they don't. بس خلص guys يعني انتوا after this session you have to know it. Squamous cell lung carcinoma, hypercalcemia because of PTH related peptide. إذا كان عندنا a patient with something like myasthenia gravis or something like SIADH or Cushing syndrome, what is it? It's small cell lung carcinoma. A female non-smoker or anyone non-smoker, adenocarcinoma. تمام؟ خلاص? Clear? Oh, if we have a tumor with مثلا someone عنده congestion in his face or he has a Horner syndrome, what do we think? Pancreas tumor. Easy? يعني guys literally this is the يعني خلاص إذا أنتوا حفظتوا this, trust me, no question about the lung فيكم تجيبوه غلط. Okay? And you guys know طبعا the histology and like squamous cell carcinoma is gonna have the pearls, the keratin pearls, and what else? صراحة that's all I remember from the histology. بس يعني the photos I'm pretty sure you guys are like gonna do well لأنه أصلا أنتوا you're studying them for OSPE, right? Anyways, let's move on. A 56-year-old man comes to the physician for a follow-up examination 1 week after a chest x-ray showed a solitary pulmonary nodule. Hello? So he has a nodule. He has no major medical illnesses. He smoked 1 pack of cigarettes daily. Physical shows no abnormalities. A TB test is negative. CT shows a 2.1 centimeter well-circumscribed calcified nodule in the periphery of the right lower lung. So they did a biopsy and then they saw إنه عندنا disorganized hyaline cartilage okay, hamartoma. صح. Why is it hamartoma? Because أصلا guys, if you look at it, it doesn't give like cancer vibes because there's no weight loss, there's no hemoptysis, there's no dry cough. Like أصلا it's an incidental finding. يعني he went just for an examination and then he did an x-ray and then like he found it. تمام. So it would make sense when it's a pulmonary hamartoma. Okay, and it's calcified. Well, plus, guys, if you look at how it's and how it's shown, it's like well circumscribed. Like it's not irregular borders وهيك. It doesn't give malignant vibes. تمام? يلا. A 17-year-old boy is brought to the physician because of a 3-week history of persistent cough and shortness of breath. Over the past 5 months, he has recurrent episodes of pneumonia treated with antibiotics without full recovery. He does not have a history of serious illness. He does not smoke or drink alcohol. His temperature is 36.8, normal, pulse is fine, respiration is fine, but his blood pressure is increased. There's a dullness to percussion over the right lung field. An X-ray showed a pulmonary nodule. And a contrast enhanced CT scan of the chest shows the nodule is 22 millimeters in diameter, contrast enhancing, not important. And then they saw this thing. What do you guys think this is? He's young. Wait, before you jump into conclusions. He's young and it's in the central portion and his blood pressure is high. And he's young, guys. E. Lung adenocarcinoma? Carcinoid? It is carcinoid. Because أولاً he's a young patient. So it doesn't يعني in young patients adeno because it looks like a gland. Actually it's okay, I get why you think it looks like a gland, but إنه هي هدول they're B cells because it's not B cells, wait, never mind. they are what are these cells? They're neuroendocrine cells. I'm pretty sure they are neuroendocrine cells. Okay, فthey form هيك انه they look monomorphic. هيك they look all the same. Like if you look at it, I'm not sure if the doctor who they are neuroendocrine cells, but I'm not sure if the doctor included a photo. But you guys look at these, they look هيك all the same, right? It's like the same one duplicating. It looks like a homonymous, like I don't know what the word is, but I know like all of them are the same. Okay. And he's really young. Yani, it doesn't make sense for a very young patient to have blood pressure. That's number one. And number two, and not like a cancer in his lung. Do you guys think like someone who's 17 would have a squamous cell carcinoma and he's not even a smoker? Did we take carcinoid? Yeah, I was in your I saw carcinoid in your slides. Monogamous, yeah. Monotonous cells. Yes, exactly. I'm pretty sure you guys took carcinoid, صح? I saw it in your slides, like yeah, okay. Anyways, it's fine. Even if you guys don't remember it, now you remember it. If you see a young patient, or maybe he might be old, by the way, but if you look at if you look at the photo in here, they're all like the same. They look the same. They don't look like malignant and scary. لا بالعكس. Plus, we have blood pressure is increased because in carcinoid, we have like you know how in like they secrete like norepinephrine and heck they secrete stuff that will increase the blood pressure تمام. And he will get all the other like إنه مثلا he might feel overstimulated heck. Do you get me? Oh, they don't release norepinephrine, they release serotonin. تمام. Is this clear, guys? Plus, look, bronchial carcinoid tumor is the most common primary lung in children. So because he's a child, you can think of carcinoid tumor. But in your lecture, the doctor mentioned that carcinoid is associated with serotonin, and so on. تمام? Shall I move on? If you want me to explain more, I don't mind. Plus, I'll move on. No one is saying. Come on. طيب يلا. A 67-year-old woman comes to the physician because of a 4-month history of chest pain, progressive shortness of breath with exertion, and a 5-kilogram weight loss. The patient also reports daily coughing in the morning that has been worsening over the past few months. Medical history is remarkable for chronic obstructive pulmonary disease and gout. She worked in a wiring shop for 35 years and retired 2 days ago. Okay. She has smoked. Her medications are whatever. She is let's see what is important. Exactly, working in a wiring shop, asymmetric chest wall expansion, and you can see the CT scan, guys. You can see that there is something white around the lung. Everyone is saying B, you guys are right. It's mesothelioma, or whatever it is. It is usually secondary to asbestos exposure, okay? And as you guys saw here, we have like the pleural tissue is thickening. تمام? Is this clear? It's easy, صح? I think so. تمام. An investigator is studying early postmortem changes in the lung. Autopsies are performed in patients who died following recent hospital admission. Microscopic examination of the lungs at one of the autopsies shows numerous macrophages with brown intracytoplasmic inclusions. Okay? A Persian blue stain causes these inclusions to turn purple. So, what do you guys think this is? إذا عنا نحن brown intracytoplasmic inclusions. This gives what? Don't only think of the lung يعني think of the heart كمان. إذا نحن عنا هدول lipid we think of asbestosis. Oh صح, that is true. اللي هي pharyngeus brown thing. You're right. But I think Okay, I think this question is for okay تمام. Asbestosis. طيب okay, if we're assuming إنه نحن عنا asbestosis, what would we expect? Will we have diaphoresis that worsens at night? No, because it doesn't have to do with night or day. Would we have dry cough that worsens early in the morning? Maybe, but like, I don't know. No, I don't think so. Maybe. Let's just put it as a maybe. Purulent expectoration that worsens in the lateral recumbent position. So we're going to have like sputum production and so on. I don't think so. Do you guys think so? No. Lower extremity swelling that worsens on standing. No, I don't think so. طيب, chest pain that improves when leaning forward. Maybe. Shortness of breath that worsens when supine. No, let's see. It's actually it. Because we're having hemosiderin containing macrophages. Okay, this is heart failure. Tamam? Asbestosis, what you said was correct, and no, like the brown thing, but it's not. Hon, they're talking about brown intercystoplasmic inclusions. This is very high yield for the brown, the lipid, the hemosiderin containing macrophages. تمام? Hemosiderin containing macrophages are usually found لما يكون في عنا heart failure. Okay? So if we have heart failure, okay, now let's approach these things knowing that we have heart failure. تمام? Will we have diaphoresis that worsens at night? No, because it will be all the time. صح? Will we have dry cough that worsens early in the morning? We might have a dry cough, but it's not going to become worse in the morning. So it doesn't have to do with that. Purulent expector? No. Lower extremity swelling that worsens on standing? No. بالعكس, like the problem is not from the right side. The problem is from the left side. Okay? It's not going to cause D. Chest pain that improves when leaning forward. This is basically pericarditis or like anything that involves the pericardium. The thing that makes sense, shortness of breath that worsens when supine, because in heart failure, what do we have, guys? Orthopnea, right? And what is orthopnea? Orthopnea means إنه لما they go to sleep, they can't sleep supine. Why? Because the fluid in the lungs are going to basically obstruct their breathing, but they need the elevated pillows. تمام? Is this clear? Okay. هو maybe guys انه it was a bit not clear انه this is heart failure لانه انا حتى يعني I was like what is this? It might be like I don't know, someone sent asbestosis and you're right, it might be, but the asbestosis doesn't look like that, okay? Like it's not going to be the hemosiderin containing macrophages or the intracystoplasmic brown thing. تمام؟ يلا. على فكرة ما بقي غير a couple of questions, let's power through. A 67-year-old woman comes to the physician because of progressive swelling of her legs, shortness of breath on exertion, and abdominal discomfort for the past 3 months. And the swelling of her legs, shortness of breath on exertion. What do you guys think? She also had nausea and decreased appetite, resulting in a 6-kilogram weight loss. She's being treated with paclitaxel for ovarian cancer and had 2 episodes of pulmonary embolism. Hello? Okay. The patient has smoked 1 pack of cigarettes daily for 25 years, drinks 2 glasses of wine. She appears tired. The patient is 164. Okay, these are not important. Pulse is elevated. Blood pressure is elevated. عنا ascites and pitting edema. So what do you guys think this is? It's okay, bye. But guys, الباقيين, what do you think this? C. Do you agree, guys, that it's C? It makes sense because we have ascites, we have like عنا hepatic congestion. Hepatic congestion would mean right ventricular failure because we have venous congestion. تمام? Is this clear? I think it is. يلا guys, ما بقي غير a couple of questions. I think this is the last question, I think. A 45-year-old man comes to the physician for a routine health maintenance. Okay, he feels well. He underwent appendectomy at the age of 25. He has a history of hypercholesteremia, blah, blah, blah. His father died at myocardial infarction. The patient does not smoke or drink alcohol. His vital signs are within the normal. Cardiopulmonary examination shows the following. ال ECG اللي هلا. طيب يلا. Can someone tell me, can someone describe the ECG for me? But I want you to describe it but the right way, like the, you know, like the steps. Complete dissociation, 3rd degree. Are you sure? Rate برادي صح bradycardia. طيب rhythm irregular. Okay. But guys, do you think it's a خلاص 3rd degree? Okay, I gave you the answer. My bad. But do you think هلا ليش it's not a 3rd degree? Because look at here. هلا عنا one. This is the first one. بعدين look how okay, let's count how many, like okay, عنا 1 2 3. This is the first pulse. The second one عنا a space and then 1 2 3 and then I said 3rd block because the P waves aren't coordinated QRS. Where's the dropped beat? So basically, okay, let's check it together. تمام? So basically, Anna, this is the first one, and then it increases, and then this is the like the normal اللي هو the difference between the two. تمام? Then this is the second one. It gets shorter. Okay, and then we have the P, and then it disappears. اللي هي هون, the beat that's here, it disappears. And then we go again. It goes back to the normal, and then it disappears again. Do you get me? Because like شوفوا, this is a P, QRS, T, P, QRS, T, P, QRS, T, P, nothing. Then P, QRS, T, P, QRS, T, P, nothing. And then, yeah, it is Mobit's number 1. Is it clear? ولا لا? So we have a steady increase in the PR interval until poof. Guys, did they tell you the story? اللي هي basically which is more dangerous, like 1 or 2? Mobit's type 1 or Mobit's type 2? Did they tell you the story? Like, so you remember why type 2 is more? No? So basically, my TA, when I was a 3rd year, told us that, basically, in type 1, the PR interval is going to increase, 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 and then it's going to disappear. So, يعني في عنا something, يعني you're getting, يعني you're kind of, the story that she told us, no, basically, we have 2 scenarios. A wife and a husband, okay? So in the Mobit's type 1, the husband, يعني it's showing slowly that he doesn't care anymore, he doesn't care anymore, he doesn't care anymore, and then he just leaves. تمام? But in type 2, he doesn't show that he doesn't care. لا, he's there, and he's there عادي, then suddenly he disappears. For which one is more like, يعني إنه هيك more, the shock would be worse? Type 2, لأنه the husband was normal, but then suddenly he disappeared without مثلا showing إنه he doesn't care. فإن type 1, we have the PR interval increase. So the PR is slowly increasing, 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 and then the beat is dropped. But in type 2, no, عندنا a sudden deep dropped beat that wasn't even يعني preceded by anything. So that's why it's worse. تمام? But I still remember the story لهلا. Anyways, I think we're done. Thank you guys. Please scan this code. Please, or write any feedback you have. And if you guys have any questions, this is my information. You can text me, you can email me, اللي بدكم. I hope I helped, guys. If you actually need anything, you can always text me. وإن شاء الله الله يوفقكم يا رب. It's gonna be okay. And for whatever questions that were weird, and I said, let's appeal and skip, just skip them, like for the people who are watching the recording. تمام? Thank you guys. Allah يوفقكم يا رب. We can stop the recording, I think.